So now we are going to start a new playlist, and this playlist is all about the pathologies of the retina, the diseases of the retina. And you know that the disease is all about the pathophysiology, right? And in this video, we will start a basic terminologies regarding the retina, regarding the diseases of the retina, regarding the pathologies of the retina, right? We have different retinal pathologies. We have different retinal diseases like retinal detachment, like retinopathy of prematurity, like retinoblastoma, like ARMD, age-related macular degeneration, and so on, right? So in this video, we will discuss basic terminologies regarding the diabetic retinopathy. So first of all, we must have some knowledge about the diabetes mellitus, which is actually a systemic disease. So the type 1 diabetes mellitus is actually a genetic condition which shows up early in life, right? And if we discuss about the type 2 diabetes mellitus, this type 2 diabetes mellitus is actually lifestyle dependent. Suppose if I'm taking so much sugar, right? If I'm taking so much sugar, it can cause diabetes mellitus type 2. And if we make many differences, if we make further differences between type 1 diabetes mellitus and type 2 diabetes mellitus, so type 1 diabetes mellitus, for example, my body weight is normal, right? And you know that the insulin is used as the breaking down of the macromolecules, the greater molecules of the sugar, right? And it convert macromolecules into micromolecules of the sugar, right? So the sugar level can flow in the bloodstream easily, right? So if I have normal body weight, but the insulin production in my body is not sufficient, is insufficient for the breaking down of the sugar in my bloodstream. So that type of diabetes mellitus is called the type 1 diabetes mellitus, right? And now type 2 diabetes mellitus. The type 2 diabetes mellitus, you know that it is lifestyle dependent. If I'm taking so much sugar and I'm getting obese, right? Obesity is very much, right? So it means the obesity is very high, right? But the insulin production in that body which is obese is not sufficient. The insulin production is normal, but that normal production of the insulin is not sufficient for that obese body, right? So that kind of diabetes mellitus is called type 2 diabetes mellitus. And now we will discuss about the diabetic retinopathy. So what is actually the diabetic retinopathy? Right, as name indicates, it's diabetic retinopathy, right? The worst stage of the retina, the pathology of the retinopathy, right? Due to the hyperglycemia, due to the increase in the sugar level of the bloodstream. If I have so much sugar in my blood, if I have macromolecules in my sugar, if I have macromolecules of sugar in my bloodstream, then it can affect my eye, it can affect my retina, it can affect my fundus, right? So that bad effect, that worse effect of my retina due to the increase in the sugar level in my bloodstream, this is called the diabetic retinopathy. And if we discuss about the proper definition of the diabetic retinopathy, it is the non-inflammatory disease of the retina, right, in which the retinal vasculature will get dysfunction due to the hyperglycemia, due to the increase in sugar level. So this is a proper definition of the diabetic retinopathy, right? So before learning about the diabetic retinopathy, we must have some knowledge about, that this is actually the vasculature dysfunctioning of the retina. The dysfunctioning is in the vasculature of the retina. So we must have some knowledge about the microvascular or microvasculature of the retina. It means we must have some knowledge about the blood supply or arterial system in the retina. We have a detailed video regarding the whole arterial system of the eyeball, right? And in this video, we will discuss shortly and briefly regarding the vasculature of the blood supply to the retina. You know that the first blood supply, the whole blood supply is actually coming from the heart, and internal carotid artery is taking the whole blood towards the different structures, and one of them is retina, right? So the internal carotid artery, which is coming from the heart, it taking the oxygenated blood from the heart, and then the sub branch of the internal carotid artery is, the ophthalmic artery, And the ophthalmic artery has different branches, sub-branches, ophthalmic artery. And ophthalmic artery has different sub-branches, and one of them is central retinal artery, right? So the central retinal artery, which is a sub-branch of the ophthalmic artery, it will come over here and it will pulse in the dura mater of the optic nerve, right? Here, it will penetrate in the dura mater. After penetrating in the dura mater, it will go towards the weakest portion of the sclera. You know the sclera, the white of the eye, the 5/6 of the eyeball, the fibrous layer of the eyeball, right? So this central retinal artery, CRA, it means central retinal artery. Internal carotid artery, it comes into the ophthalmic artery, then it goes to the central retinal artery, right? So central retinal artery will pierce in the dura mater, and then it will pass through the weakest point of the sclera, which is called lamina cribrosa. Right? So lamina cribrosa has different perforations, different holes. So central retinal artery will pass through the lamina cribrosa, weakest of the sclera, and then it will pass through the optic disc, right? And after piercing in the optic disc, the central retinal artery will go in superior branch and inferior branch in the retina, right? And this superior branch will convert into two, superior nasal and superior temporal, and this inferior branch will convert into superior nasal and superior temporal, right? So this is about the central retinal artery. And now another branch, another supply, which is short posterior ciliary artery, internal carotid artery, ophthalmic artery, and the sub branch of the ophthalmic artery is short posterior ciliary artery, right? One of them was central retinal artery, the pathway is that, and next one is short posterior ciliary artery, and it's coming from the same way, internal carotid artery and ophthalmic artery. So short posterior ciliary artery will come and it will pierce directly in the sclera, right? You can see over here the central retinal artery was piercing in the dura mater, and then lamina cribrosa, and then optic disc, and then further, right? But the short posterior ciliary artery will come over here, it will pierce directly in the sclera, right? And it will travel between the space which is called the suprachoroidal lamina, right? Between the sclera and the choroid, there is a space between the sclera and choroid, right? So that space is called suprachoroidal lamina, right? It will travel through suprachoroidal lamina and then it will pass towards the retina. So you have to keep it in mind that short posterior ciliary artery will come through the internal carotid artery, then ophthalmic artery, then sub branch of ophthalmic artery is short posterior ciliary artery. The short posterior ciliary artery will pierce into the sclera directly. It will travel through for some time in the suprachoroidal lamina, and then it will give supply to the choroid, right? And after giving supply to the choroid, it will penetrate into the retina, right? But this short posterior ciliary artery will give supply to the outer 5 layers of the retina. You have to keep it in mind. This is important point, that short posterior ciliary artery will give its nourishment, arterial nourishment, blood nourishment to the outer 5 layers of the retina. You know, retina has 10 layers, right? And the central retinal artery, which is coming from the same way, internal carotid artery, ophthalmic artery, and then central retinal artery, it will pierce into the optic nerve, dura mater of the optic nerve, then lamina cribrosa, optic disc, and then it will give supply to the inner 5 layers of the retina, right? So another artery is the cilioretinal artery, cilioretinal artery, right? This cilioretinal artery is actually the part of the short posterior ciliary arteries. It's part of that system, right? And it will give supply to the optic disc over here, right? So these are 3 different pathways for the blood supply towards the retina. right? And now we will discuss about the different barriers, which is called blood retinal barriers, which is most important before learning about the diabetic retinopathy. Now first we will discuss about the outer blood retinal barrier. There are two types of blood retinal barrier. The first one is outer blood retinal barrier and the second one is the inner blood retinal barriers. These two barriers are most important if you want to learn about the diabetic retinopathy, if you want to learn any of the disease of the retina, right? So this is eyeball, and you know that the outer black actually the sclera. In fact, the sclera is in white color, the white of the eye. But in this video, in this whiteboard, that black color is actually representing the white of the eye, which is sclera. Beneath the sclera, this red marker is actually representing, denoting the choroid, right? We are coming from outside to inside. The most outside, right, or you can say the most anterior from that side, it's sclera. Beneath the sclera, there is choroid, the red in marker, right, the red in color, and beneath the choroid, beneath the red choroid, there is blue marker, which is actually representing the retina. Which part of retina? The retinal pigmented epithelium, which is first layer of the retina. And beneath the retinal pigmented epithelium, which is in blue color, beneath that, this black marker is actually representing the rest of the retina, which is called the sensory retina, which is actually the neuronal retina, right? So I will zoom out that portion over here, and then we will learn about the outer blood retinal barrier, right? So first structure was sclera. This is sclera. The next one was choroid. Then in the blue marker is retinal pigmented epithelium. This is sclera. This is red in marker. This is choroid, and this is retinal pigmented epithelium. And beneath the retinal pigmented epithelium, there is sensory retina. As name indicates that this portion is very sensitive to light, right? And we have to protect this portion of the retina in any case, in any cost, right? So what is actually the outer blood retinal barrier? You know that the outer blood retinal barrier is at the, if we talk about the location of the outer blood retinal barrier, then the outer blood retinal barrier is actually at the level of the retinal pigmented epithelium, right? This is sclera, the first one. Next one is choroid, and next to the choroid is retinal pigmented epithelium. So the outer blood retinal barrier is actually at the level of the retinal pigmented epithelium, right? So there is specialized cells in the endothelial cells of the retinal pigmented epithelium. I repeat, there are some specialized cells which are at the level of the endothelial cells of the retinal pigmented epithelium, right? These specialized cells are compact. They are strictly adherently attached with each other, right? So you know that in the choroid, the blood flow freely without any restrictions, and it can travel in the retinal pigmented epithelium. But there is a outer blood retinal barrier at the level of retinal pigmented epithelium, which is in the compact form, you can see over here. And these outer blood retinal barrier would not allow any blood in the sensory retina. And you remember, if this outer blood retinal barrier, which is at the level of retinal pigmented epithelium, if this outer blood retinal barrier goes break, then the problem will start. The problem with the retina will start. It will damage the retina, it will hurt the retina, it will destroy the retina, right? So this outer blood retinal barrier is that important, is that essential for the life of the retina, to make the retina alive, right? So you can say The blood is restricted over here at the level of retinal pigmented epithelium, but the blood cannot move towards the sensory retina. You can say some nourishment like oxygen, the oxygen can travel from the retinal pigmented epithelium towards the sensory retina because the oxygen is very necessary for the living of the retina, right? So oxygen and some important nutrients, some selective nutrients. The sensory retina is actually a red zone, and only selective persons are allowed to go in the red zone, right? So oxygen is a selective person, and the only oxygen can penetrate through the retinal pigmented epithelium towards the sensory retina, right? So this is called the retinal, the outer blood retinal barrier, which is at the level of the retinal pigmented epithelium. And now we will discuss about the inner blood retinal barrier. You know that the inner blood retinal barrier, we have discussed about the location of the outer blood retinal barrier, and that is retinal pigmented epithelium. And now what about the inner blood retinal barrier? The inner blood retinal barrier is actually at the level of the capillaries of the retina. You know that we have discussed about the arterial system or blood supply towards the retina. The central retinal artery was coming from internal carotid artery, ophthalmic artery, and then central retinal artery was piercing in the dura mater, then passing through the lamina cribrosa and then optic disc, and it will go superior and inferior. And now there were two branches, inferior temporal, inferior nasal. This is inferior nasal and this is inferior temporal, suppose, and this is this is superior temporal and superior nasal, and this is inferior temporal and nasal. We have four different branches of that arterial system, right? And you know that the arteries, which are bigger blood vessel, it will go further. Smaller arterioles, these are arteries. Arteries will go into the arterioles, which are smaller in size. Arterioles will open up in the capillaries, which are most smaller in size, and then arteries will give its blood to the venules, and venules will open up in the bigger blood vessels, which are called veins. So first of all, the oxygenated blood will come over here in the arteries from the heart. Arteries will give its blood to the arterioles. Arterioles will give the oxygenated blood towards the capillaries, and at the level of capillaries, this is important point, you have to keep it in mind that at the level of capillaries, the exchange of gases will occur over here at the level of capillaries, right? Because this is oxygenated blood which is coming from arteries and arterioles, the capillaries will give oxygenated blood, this is O2, oxygenated blood toward the structures like retina or whatever, and then it will return the deoxygenated blood, the CO2 blood, towards the capillaries, and then capillaries will give deoxygenated blood to the venules, and then venules will put that deoxygenated blood towards the veins, and then veins will take the deoxygenated blood towards the heart. So this is the procedure, right? So what about if we talk about the inner blood retinal barrier? So I will say that the inner blood retinal barrier is actually at the level of capillaries here, right? So they are too small to show the capillaries, right? So I'll make a bigger capillary over here. Suppose this is capillary. This is capillary, which is in the red marker, and I have made some specialized cells in the blue marker, and these specialized cells are called pericytes, right? These pericytes are very special. These pericyte cells are very essential. These pericyte cells are very important in the retina, in the capillary, right? How and why? You know that what is the function of these pericytes? These pericytes have they have multifunctions, right? The regularity of the blood flow, this is the most important function of these pericytes, the regulation of the blood flow. The most important function of the pericytes is angiogenesis. This is another most important function, and the most important function of these pericytes is the structural integrity of the capillaries, right? So these pericytes are actually in the endothelial cells of the capillaries, right? What is the location of the pericytes? At the level of the endothelial cells of the capillary, right? You have to make a difference over here. The outer blood retinal barrier was at the level of retinal pigmented epithelium, but the inner blood retinal barrier is actually at the level of the endothelial cells of the capillary, of the retinal capillary, right? So these parasites are tightly bounded with each other. They would not allow the blood which is inside the capillary to come out of the capillaries, right? So these parasites are actually making the structural integrity of the capillaries, right? They would not allow any blood or any content of the blood like red blood cells, like white blood cells, macrophages, plasma, platelets. They would not allow any of these coming out of the capillaries, right? This is actually the life of the retina. If these contents, if the blood is inside, if the blood is confined in the capillaries, then the retina is fine, the retina is all right, the retina is alive. And if this inner blood retinal barrier goes ruptured, then all the blood and contents of the blood will come out of this in the retinal tissues, and then the destruction of the retina will start. So this is actually the inner blood retinal barrier. And now we will finally discuss about the diabetic retinopathy. And now we will start the pathophysiology of the diabetic retinopathy, right? So first of all, we will discuss about, if we want to learn about the pathophysiology, then we have to discuss the two different procedures of the diabetic retinopathy. The first one is called the microvascular leakage, and the second one is called the microvascular occlusion. And in this video, we will end up our video at the microvascular leakage, right? So what is actually the microvascular leakage? As the name indicates, that microvascular leakage. What does it mean when we say microvascular? It means capillaries, because the capillaries are the smallest form of the blood vessel. So we have discussed about the inner blood retinal barrier, and now if I'll make a bigger capillary this time, this is a capillary of the retina, right? And these are our specialized cells, which are, I want to hear from my students, but only camera is here. So this is capillary, right? And these cells, which are specialized cells in blue marker, these are pericytes, which are intact. And if the blood is getting more and more macromolecules, MACRO, right? The bigger molecules of the sugar. You know that if I have a bigger molecule in my bloodstream, then my arteries are bigger in size. I'm talking about these arteries. They are bigger in size. But the arteries in my, or capillaries in my blood, in my retina, in my eye, right? And in my brain, these capillaries are smaller in size, very, very smaller in size, right? So because of the smallest size of these capillaries, the macromolecules, the bigger molecules, the sugar, cannot pass through those capillaries. So then they will hit the walls of the capillary, right? Suppose macromolecules, I can write it for you, macromolecules, because I'm not satisfied. So you can make a better difference between macro and micro. I'm talking about macro, the bigger molecules of the sugar. So if bigger molecules of the sugar will come in the capillary, so this is sugar molecules. So you know that the size of this sugar molecules is bigger, right? So it can harm, it can affect the walls of the capillary. So when it will hit the wall of the capillary, then the caliber of the wall of the capillaries will affect, right? It will harm the walls of the capillaries, right? And when it will hit the capillary wall, then it will cause the loss of parasites. We have already discussed that what is actually the importance of the parasites. It will make, it will cause the structural integrity of the capillaries. So if parasites will release over here, the parasites are releasing. So this specific point over here, where the wall is weaker than the rest of the wall, because the parasites have released over here. So when the parasites have released, so there is no parasites over here, right? So at that focal point, at that specific point, the parasites have released, and now the structural integrity of the capillary wall is loose. So at those specific points where the parasites have released, the parasites have lost, at that specific point, the wall of the capillary will get dilate like this. It will make a outpouch at the specific point where the parasites have lost. At that specific point, a focal dilatation will occur at the wall of the capillaries, right? So that specific focal dilatation of the capillary wall is called the microaneurysms. What is called? Microaneurysms. And you have to keep it in mind that the microaneurysm is actually the hallmark. The microaneurysm is actually the cardinal sign. The microaneurysm is actually the starting pathological point in diabetic retinopathy, right? So what is actually microaneurysms? The microaneurysms, the parasite will lost at specific point, at any focal point, the parasite will lost. The wall of the capillary will come out, will make a outpouch, it will make a focal dilatation, and that focal dilatation of the capillary wall is called the microaneurysm. This outpouch is called the microaneurysms. And now when microaneurysms is there in the retina, then the destruction of the retina is start. And now we will discuss about the different leakages from the retina, which is actually the retinal edema and the hard exudates, the soft exudates, and retinal hemorrhages. Now as you can see, the microaneurysms is formed over here. I'll make a bigger microaneurysm. This focal dilatation is called the microaneurysms, right? And now what will happen further? You know that this is a capillary, and obviously capillary is carrying the blood, and blood have different contents, like blood have red blood cells, blood has white blood cells, blood has plasma, blood has macrophages. Many of contents are there in the bloodstream, right? So first of all, because the wall is now is getting weaker and weaker and weaker and weaker, right? Microaneurysm is already there. Now you know that the plasma is here, plus RBCs, plus WBCs, plus platelets. All these contents are here in the capillaries, right? So now, as I said, that if the microaneurysm is there, the destruction of the retina is almost there. right, is definitely obviously there. So now, because the pericytes has lost, and you know that the content which is called plasma is fluid, the yellow fluid, you know. So now the plasma which has the most least density comparatively, as we compared it with the red blood cells or white blood cells or platelets, the density of the plasma is very less, very least. So first of all, the plasma will come out of this microaneurysm. As the plasma is fluid, the fluid will come out of this and it will accumulate in the retinal tissues, and it will make a water filled cavity in the retinal tissues. And now, as I said, that this is red zone. The sensory retina is a red zone. The blood should be confined in the cappileries. The blood should be confined in the arteries. The blood should be confined in the arterioles. The blood would not and should not come out of the blood vessels in the sensory retina. And if it will come out, then the destruction is obvious, right? So now destruction is over there. So now the plasma is come out of it and it make a water filled cavity, and that water filled cavity is called retinal edema. We have learned about the two terminologies. The first one was microaneurysms, the focal dilatation here in the black marker. And if the microaneurysm is there, then first of all the plasma which have the least density will come out of this and it will make a water filled cavity, and that water filled cavity in the retinal tissue is called retinal edema. So this is the second important term of the microvascular leakage. And now after that, edema is there, and now we will discuss about the hard exudates, right? What is actually the pathophysiology, what is actually the logic, what is actually the story behind the formation of the hard exudates? You know that plasma is there and plasma is out of it, and now if plasma is out of it, then it will make a retinal edema, right? So after retinal edema, plasma is out, and now with the plasma, and you can say after the plasma protein will come out of this.